You'll know when you have a wild woman. She'll practice her craft without boundaries. She is truly autonomous. Her loyalty is only to the family she serves. She will not allow herself to be held back by a system she didn't create.
This podcast is for the birth keepers who want to grow and change, who are open to learning through self-reflection and supportive community. We are creating a space to explore without judgment. We are remembering we were born wild. Hello, everyone. Welcome back to the Born Wild podcast. I'm your host, Sophia Henderson, and today I have with me Karen, who I kind of feel like you're a part of the practice in a way. For those who haven't met you, will you please introduce yourself?
Thank you, Sophia, and thank you so much for this invitation. I'm totally honored to be here. My name is Karen Miller-Hahn, and yes, I do have a Korean last name. My husband is Korean. I am not, so I tell people when I show up, you're going to see Asian showing up, not a Korean. So I've been an ultrasound tech for 25 years this year, I believe. I got my license and certification and all that in 2002, and I started studying in 2000. I am completely trained in a hospital setting. I was trained at St. Helena Hospital in the Napa Valley primarily, and also at Sutter Lakeside in Lakeport, California. And I was trained by techs that were trained for upwards of 30 years by the techs before them. So what I have is knowledge that was handed down and handed down and handed down.
The best way to hand down knowledge.
Yeah, and it was great because I learned that you can learn all you want out of a book, but especially in ultrasound, it's experience. I have to know as much as the doctor for all practical purposes because he's only reading what I'm taking pictures of. So basically, ultrasound techs are trained to take a certain set of protocol pictures for whatever scan we're doing, whether it's abdomen or OB or anything else. And then anything that deviates outside of that, outside of stone cold normal, then we take pictures of that. So I trained for 2 years with both the head tech who just retired at St. Helena Hospital and the head tech at Sutter Lakeside. And then the way the governing body of ultrasound techs works is that if you can document 800 hours of direct scanning or involved with it or anything like that, and you've got a supervising ultrasound tech that will sign off on a form that you actually know what you're doing and you're just not somebody off the street, that you can in fact sit for the boards. And so back at 2002, I sat for my obstetrical boards and also physics boards back then. And then probably about 8 years ago, I went back for vascular. So I'm also a vascular tech, and that is a different designation than the OB. The OB got me what's called a general tech, so that I'm licensed to do abdomens and carotids and all kinds of different things in addition to OB. But the vascular was a separate designation, and that entitles me that I can scan any vessels in the body, basically. So I can do anything with the body except adult hearts.
Okay.
That is a separate thing. I am getting specialized training in fetal hearts soon. I will be going to a conference in Las Vegas in a couple of months, and that's all hands-on because I feel like the hearts is where I really, really need to step up my game. I know how to take the basic heart pictures. I know how to tell if there's something looks kind of weird with it and all that. But I really want to do a deep dive into that.
And when you say just not adult hearts, do you mean like you could do pediatric?
Yeah, well, no, I believe pediatric is considered part of adult hearts.
Oh, okay. So more like fetal.
Fetal hearts. That's covered under the OB.
I was going to say, if you want to look at an interesting heart, you could use my son's.
Yes, I know. And between your son and actually I saw another one that was the same thing that your son has.
For those who don't know, my son has tetralogy of Fallot. So it's a unique heart.
He's a special kid.
Can I back you up because I want to know, like, how you even ended up being interested in doing sonography? Like, how did you end up here?
Well, Sophia, the Lord leads. The Lord leads on all of this, and I really feel like I was being led way back when. I started off as a transcriptionist, medical transcriptionist after I got out of college because my mother was a medical transcriptionist. And, and I was jobbing around with different secretarial jobs and this and that and third and fourth. And she says, hey, why don't you come and work for my doctor, and you can take over when I need to take a break and all that. So I started doing that. That led into radiology transcription at St. Helena Hospital. And that led into, at the time, the two ultrasound techs there were both male. And when they needed a female chaperone, if you will, for breast exams, for endovaginal exams, for anything that they needed a female chaperone for, they would come and get me because I was always the one that I could drop what I was doing at a moment's notice and just take off in there. And, Sophia, after looking at a lot of breasts for like a couple of years or something or other, I was like, guys, I could do this. Train me to do this. And even so, it took me probably 4 years of doing proposals to the management and all kinds of, and not taking no for an answer, And I really felt led to do this. Finally, I think the administrator in my department just kind of to shut me up. He said, fine, go do it. I don't care. Fine, go do it. And among that time, I had also been thinking of doing labor and delivery nurse. I had gotten my CNA training through the Red Cross over in Santa Rosa, and I thought that's the way I was going to do. And I was signed up for the LVN program at Napa College. And, it was weird. The closer and closer that program got to starting, the more depressed I got and the weight that was on my shoulders. And finally, one day I called them and said, I don't think this is the way for me to go. And the second I did that, that weight just lifted off my shoulders. And I was like, ultrasound, that is what I need to be doing. That is where my love is. That is where my passion is.
To stay focused.
Yeah. So I did 4 years of training at St. Helena Hospital. And between that, I think I did a couple of years down at Sutter Lakeside. And then I went and sat for my licensing boards and passed them.
How did you end up working outside of the hospital system?
Well, that has everything to do with a certain midwife by the name of Paula Grady. That used to be Schneebelt, now she's Grady. And she's the midwife in Napa and also in Santa Rosa. But she was a walking partner. She used to live in Angwin, where I live. And so she was the walking partner with a good mommy friend of mine who we did in the Adventist religion. There's there's Boy Scouts and Girl Scouts, but they're called something different. Our kids were really young. They were called adventurers. And so my friend Susan, who was a friend of Paula's, she used to cook. We used to make dinners for adventurers on all this kind of stuff. And we would talk and all this kind of stuff. So when she found out that I had gotten this machine, which I had got because I was working for a vascular vascular surgeon at St. Helena Hospital at the time, and I was going to be going into his clinic and doing all his vascular scanning, she was like, you need to talk to Paula and let her know what you're doing. So I talked to Paula, and Sophia, as you know, in the midwife community, one midwife talks to another midwife, and Paula, she was the one that had the vision. I thought I was just going to be doing pretty 3D, 4D, stuff. And she was like, wait a second. Wait. You could take this into people's homes. You could go into clinics and do this. And we wouldn't have to send them into the hospital and all that kind of stuff. And I was like, well, yeah, I probably could. And so off we went on that. And I contacted one of my radiologists that I worked with for years at St. Helena Hospital, who is semi-retired now, but he still works all over the place. So he does all of my reading for me. And I just send him all the images and what I think he's going to say on the report. And then he looks at the images. It doesn't matter where he is in the world. He can look at it on his iPad. He's just coming back from Hawaii right now. And he was reading on his iPad over there for the last 3 weeks. Yeah. So it's all the I's are dotted, all the T's are crossed. Every medical doctor around here in like 100-mile radius knows me and knows what I do. And even Kaiser, they all accept my reports.
It's so fun to hear the backstory because Paula was my preceptor and my midwife for both my children. and was already kind of working with you. So I didn't know the whole backstory. And that makes so much sense that that was her vision because she's such like a businesswoman and so creative.
Yeah, she thinks of all of these things, and I wouldn't. I mean, it would have taken me much longer to get there. She jumps there very fast.
And it's so beautiful too because what we're offering families is in home. And so it's complementary, the idea of, either in office, midwifery office, or in home. It's so fun, I think, for families to get that opportunity.
Yeah, and you know what? This is the new member of their family that's coming in. And humans, we can know something is growing in there, but we're so visual until we actually see it. I remember, oh my goodness, years ago, I had gotten called in to do an ultrasound on a girl who was probably 6, 8 weeks along, something like that. She had dragged her boyfriend in. He didn't even know what he was there for, that we were going to see the baby. And so we did that and pulled the baby up on the screen. And I have seen this, Sophia, many, many times. All of a sudden, he saw this child that he had part of. This was part of him. Suddenly, he was invested. He was there with this pregnancy. And, all the way through. I scanned them all the way through. Mm-hmm. And I even was scanning them like about 2 weeks before they delivered. Both of my children were C-sections. They were the horror stories, right? Mm-hmm. At least the first one was. And so I never had the opportunity to have a vaginal birth. And so I told them, well, I can show you what a placenta looks like on the screen, but I've never actually seen one in person. I can't tell you exactly what it looks like. And they were like, well, you have to come to our birth. And I'm like, are you kidding me? Nobody has ever invited me to their birth. And so, yeah, that morning, Paula calls me up and she's like, grab yourself a cup of tea, come on down. We're having ourselves a baby. And so I trucked down there and, oh, Sophia, it was the most beautiful, beautiful experience I've ever seen. It was the birth that we all wish we could have had. Mm-hmm. It was just like birth should be. Mm-hmm. It really was. And she birthed in their tub and her boyfriend caught the baby and I cut the cord.
Oh my God.
And Paula had me taking pictures, and it was just such a beautiful experience.
Well, I mean, that makes me think about how I was saying that if you feel like an honorary member of the team, and when you have these intimate experiences with people in their homes, even just sonography in air quotes, like it's emotional, it's, intimate. And to hear that they were so comfortable with you that they invited you into their home and you got to cut the cord that is such a cool story.
Yeah, I'm so privileged to have been a part of so many people's pregnancy journeys. To this day, I get emails from people, that their kids are 2 and 3 years along and they send me, the pictures. This particular one where I went to their house, they eventually moved to New York. She still is a Facebook friend.
Yeah.
And I can see the kids growing up. I've got on my my refrigerator, I've got, pictures that people send me at Christmas of their first Christmas pictures, and all that kind of stuff. So I'm so honored to be a part of this. I really am.
I can imagine during the height of the COVID times too, when people were having restrictions in the hospital, you couldn't even bring your partner into your appointments or to your ultrasounds or things like that. Was that a little bit different for you where you were able to offer families to stay together as a family unit and still have these special memories?
Absolutely. The business, as you probably noticed in yours, the business doubled overnight.
Yeah.
Things happened so fast.
Yeah.
Yes. So one of the big things was, in addition to being able to go into people's homes and do all of that, and also, go into people's homes, is that a lot of times when you're an ultrasound tech and you were trained by the tech in front of you, it's kind of an unwritten thing is that you need to pay it forward. You need to train the next generation and help with that. So what happened with COVID, there were student ultrasound techs out there who could not do their observation time because hospitals weren't letting them come in. And so like the doctor at the time in the OB in St. Helena, she was referring because students were calling the OB office and going, what do? We need to get training. How do we do this? And so she was referring them to me and say, well, give Karen a call. You might be able to hang out with her.
Mm-hmm.
So that's what I did. Pretty much every 2 years, I will have a student that is following me around and training anyway. But certainly during that time period, that's what happened. My goodness. And then that particular student had her training, her observation time in. She went straight into Kaiser program at Richmond when they opened up after COVID, and she is about to graduate.
Wow.
So that was a really special time. And that was one of the cool things that came out of COVID. I mean, there was a lot of not cool things, but one of the cool things was being able to do what you and I are doing right now. I mean, the Zoom whole thing just exploded, and podcasts. And
my favorite thing was being able to order something at Target and they bring it to my car.
Yes, and they still do.
Where was this when my kids were sleeping in the car as babies?
Oh my goodness, because when you're a mom, I tell you what, the drive-through is your best friend. Been there, total been there.
Yeah. When I had ultrasounds with my son, because I had a large amount of blood around like 9 weeks that kind of like poured into the toilet bowl. So I'd gone to the ER, and I remember the very first thing somebody said to me when I was in my room was, take off your clothes, put this gown on, and the doctor will be in. I was like, I'm fine just skipping the gown. And she said, the doctor can't see you unless you're wearing the gown. And I said, you and I both know that's not true. And she left the room, and I was like, it begins, and so it begins, and I remember, a couple weeks later, because they didn't give me any information on the placenta, which was what I was curious about. Is there a subchorionic hemorrhage? Where is this bleeding coming from? So I had you a couple weeks later come to my home, and it was, interesting as a student midwife to see the difference in the type of care I received and how I felt with the care I received. And I just felt like I was on guard and that I had to protect myself at the first one. And then with you, it was just like a friend coming to check on me,
Oh, bless your heart. Bless
your
heart.
Yeah.
Well, I try to be that way with everyone. I was just telling a mommy this 2 days ago because she has had this experience. I think it was at Kaiser or who knows, someplace that it was very impersonal. And she really didn't get any information at all. I don't, and that's one of the reasons that I don't work in the hospital anymore. I do independent because I never want to get to that point where a mommy, someone becomes just a number.
Mm-hmm.
Right? I never, ever want to get to that point. And I want to be able to have the time to spend with everyone. And that's why if I'm doing 2 or 3 scans in a day, I don't schedule them close together. We've got extra time in between because, maybe they've got questions. Maybe we need to spend some time looking at something or, whatever it is. Maybe they're looking for the gender and the baby is not cooperating.
Right.
And babies do things on their own time.
Yes.
And in their own way. And we just have to wait.
Yeah.
Have to wait for that. So, maybe we've got to spend more time with the baby and wait for that. So, yeah.
Will you speak to the most common ultrasounds that you perform and what you're looking for?
Yeah. So, basically I can do anything that is done in the hospital ultrasounds, with the caveat that I don't use contrast. I've just started doing fertility scans for moms that are working on getting pregnant and doing the follicle monitoring and all that kind of thing. And so there is one thing that I can't do, and that is contrast injections and doing ultrasound. But everything else, basically with an OB situation, obstetrical situation, we start. I can see the gestational sac at 3 weeks. Basically, the time when the pregnancy test turns positive. That's when I can see that little tiny pinpoint in the endometrium. Usually in a medical situation, you would have your first ultrasound at 7 weeks, 8 weeks. And so I can do that.
And other than it just being routine, why might somebody actively choose it? What information can they get from it?
Well, if you wait at 7 weeks, and that's why I try to push them a little bit longer to 7, 8 weeks, something like that, we should by 6 to 7 weeks from the outside, the transabdominal. This is not going inside.
Maybe people don't even realize that there are two options.
Yeah, there are two. Thank you for leading me into that. If you go to a regular medical practice, they are most likely going to do an endovaginal scan around 6, 7 weeks, something like that. And anybody who hasn't had that done, it's like a great big tampon, if you will, that goes up inside like you would put a tampon in.
Mm-hmm.
And so we can see a little earlier the heartbeat like 6 weeks or 5.5 weeks, something like that. Now, I choose not to do that. I choose to say, let's go 7, 8 weeks if we can, unless there's a question of ectopic pregnancy or something or other that we need to look, because I don't want to introduce a theoretical source of infection. Yes, we sterilize. Yes, we put probe covers on. I use sterile gel. I use the whole 9 yards. We keep it sterile. But still, there is a theoretical risk of it. And I'm not going to risk that with somebody unless we do a scan at 7 weeks and I see an empty uterus. Then we have to start looking out in the ovaries and looking where else this might be. If you've got a positive pregnancy test, you've got a baby in there somewhere. Let's find it. So, assuming everything's great, that's one of the reasons to do it that early. The second reason is let's date this pregnancy. Let's get a gestational age on it, because all babies grow at a steady rate up through the first trimester into the second trimester. And at 7 weeks, we can get a really good, accurate assessment of how big that baby is and what your date of completion is. And whatever date we get at that first ultrasound, that is your date, barring that you have gestational diabetes or who knows what goes on later in the pregnancy. Very little will change that date. That's going to be your date. And so that will be your date through the end of the pregnancy, barring any sort of gestational diabetes or intrauterine growth restriction or anything weird that happens, but that usually doesn't happen. So that is the reason to do an early one like that. And then the second one we usually do is around 19 to 23 weeks. 19 to 23 weeks is the window to do like an anatomy scan. And if you have it done in a hospital, they're going to shoot for like 20 weeks. I prefer, if there's no other reason to do it right then, that it has to be done right then, I prefer to push it more like 22 weeks in there. And the reason being is because the hearts are bigger.
Mm-hmm.
And the baby's bigger and the hearts are bigger. Everything's bigger. I want to be able to see the inflow and the outflow tracks on that heart really well. And if you shoot for 20 weeks, usually the women that we worked with that are doing home births and all that, they're really accurate on their dates. They know when this conception happened. They know when all of that. But sometimes you'll get somebody that comes in at 20 weeks and they're really more like 18 and a half, and the baby.
Especially if women are like breastfeeding continuously and then all of a sudden they're like, they just get this like inkling that maybe they should take a test and they're like, I really don't know when I got pregnant because I didn't have a cycle.
Yeah, I have a lot of women that come through like that. So that's another reason. And the reason to do it within 19 to 23 weeks is that there are some structures in the brain, in the autonomic nervous system. And those are most accurate within that time period, 19 to 23 weeks. That doesn't mean that after 23 weeks, we can't do the anatomy scan. I've done anatomy scans all the way up to 38 weeks. And it's just that after about 23 weeks, there's the structures like the lateral ventricle in the brain. It gets squeezed down to like a little worm because the brain is developing so much. And we can't see it. We can't see it. So that's another reason to do it within that time period. So I shoot for about 22, 23 weeks, but we can do it whenever. So there's those two. There's the early one, there's the anatomy one. And then if anything is seen on the anatomy scan, I said earlier, ultrasound techs are trained to take pictures of anything outside of stone cold normal, which can be variations on your baby. Your baby can be just variations on whatever, heartbeat, anything. The most common things I will see are like the placenta will be too close to the cervix. And by too close, we mean less than 2 centimeters with boys. I tend to see fluid backing up into the kidneys. You'll get these little black spots in the kidneys, and it's a thing. I'm not God. I don't know why they were created this way, but with the male fetus, the ureter, the way it attaches into the kidney, it can get kinked and urine can back up. So, and then after they're born, they straighten out and everything flows and everybody's happy. But
so that's a common thing you see,
that's a
but
real
you
common.
usually see it resolve.
Yeah, I see with boys, I see that about 5, maybe 6 out of 10 boys. It is really common. My son had it. So in those cases, my radiologist always says, well, you bought yourself a follow-up. So I'll come back at like 30, 32 weeks, something or other, and we'll take another look at like the placenta. In a hospital setting, a lot of times the doctors will lose their cookies over that placenta being too close. In the midwifery community, everybody kind of seriously rolls their eyes and says, okay. Because what happens is as the top of the uterus grows up, as the baby gets bigger, it's going to pull that placenta up with it. It's never going to go down. It's only going to go up. In my 25 years, I have never seen one go to a C-section with the placenta didn't move. They always move. Everything that I've watched. Every once in a while, that one that hasn't been watched through an ultrasound. So this is the two reasons that I tell women why to have an ultrasound at 20 weeks. If I was doing a home birth, I would want to know where that placenta is, how close it is to the cervix. I would want to know where the cord is attached on the placenta. It's usually attached in the middle or the upper, but I have seen it where it's attached on the very bottom edge, and I have seen it where it is completely off the placenta on the uterus itself. And so in those cases,
on the uterus or the membranes?
On the membranes inside the uterus.
I was trying to picture how it was on the uterus.
Yeah, no, thank you.
Whoa.
Yeah, no, it's rare, but it does happen.
Yes.
It does happen. And in those cases, you need to be following up on the baby. And also in the case of the delivery, it's one of those things. If the midwife knows, then they will not be pulling on that cord to help the placenta guide it out. They're just going to let it come.
Use gravity.
Yeah, use gravity. So there's those three. So you have your early one, you have your anatomy one, and then if you have any follow-ups, we would do that about 32 weeks to check on things, make sure everything's fine. If you go over dates, if you go like 41 weeks, something like that, 41 and a half, I get called in because we do what's called a biophysical profile at that point. And we're looking at the amniotic fluid, making sure that there's enough that you can continue safely. We want to see the heartbeat, what's called fetal cardiac variability. We want to see the heart rate speed up and slow down. That's perfectly normal. We want to see that baby kicking, which that baby's kicking, and the hands opening and closing. And then we want to see something called fetal breathing movements. They're not actually breathing in there. However, the autonomic nervous system is developed to the point that we will see the chest heaving back and forth. So we know that when that baby comes out, it's not going to have a problem breathing. So in a 20-minute scan, that's the only one that's timed. In a 20-minute scan, we want to be able to see those breathing movements and the cardiac variability, measure the amniotic fluid, hands opening and closing, kicks, all that kind of thing. We want to be able to see all of that. And you get a score, basically, a score with that. And those are good for 3 days because of the amniotic fluid. And most of the time, I was just telling somebody this the other day, most of the time, delivery happens within a day or two after that. If it doesn't, then I come back 3 or 4 days later and we measure the amniotic fluid again. In 25 years, I think the most I've ever done is maybe 3 of those on a mommy until she finally delivered. But that is very rare.
Yeah.
Very rare.
One thing that I always kind of chuckle at when I'm reading reports is how they call the placenta unremarkable. Because what could be more remarkable than a placenta? But it's theoretically a good thing to be called unremarkable. Why did they choose that languaging, Karen? Do you know?
It's just shorthand. I use it myself when I'm sending a report to the radiologist. I'll say, oh, this is a 20-week anatomy scan. Unremarkable.
It was unremarkable.
Unremarkable. Everything was great on it. And I tell everybody that I scan, everybody has something unique with them, a lot of things unique with them. If I scan anybody, I don't care who it is, for long enough, I'm going to see something that's out of the ordinary. And placentas is one of those places. Placenta, nobody's placenta is the same. Everybody's is different. And, you might have little vascular lakes, little dark spots in them, or, where they might be attached. I just saw one last weekend where it is attached on the backside, it's attached on the front, and then it comes down. I mean, it's attached on the top, and then it comes down over the front. And that's normal for her. And yeah, so it can just be different things, different things.
Yeah.
Yeah, but the placenta is an amazing organ.
And you got to see one. That's awesome.
Yeah, and I tell people, the placenta, as long as it's not over the cervix, we really don't care where it's attached in there, as long as it's functioning.
Yeah. Can you speak to risks in ultrasound? Because that is a big thing with families when they're trying to there's one thing to just do things routinely. And we have some families who are like, whatever's recommended, we want to do. And some families who are picking and choosing based off of benefits, risks. Can you speak to risks in terms of ultrasound, and maybe depending on the dates too, if it matters?
Yes, it does, actually. And thank you for bringing that up. That is a big thing.
And actually, one short story too, because I only heard it once. I've never heard it again. So I'd love to hear your take on it. When my brother and his wife were pregnant, they had Kaiser, and I might butcher the story, but my memory is that they asked about an early ultrasound and they were told that we don't do it before 10 weeks because it increases the rate of heart defects. And I've never heard anyone say that again. And I don't know if they said it because my son had a heart defect and maybe they revealed that to them. I have no idea, but it always just stuck in my head. I've never heard anyone else say it again. And lots of people have ultrasounds, before 10 weeks. So just wanted to say that if you can speak to that, if you have heard anything.
Not on the heart defects specifically.
Okay.
But there is a thing in ultrasound that we are all trained in from day one. And it is a mnemonic, ALARA, Alara, and it is something to the effect of as low as reasonably achievable to get the pictures. So what that means is we basically do not want to do any scanning. We don't have a higher frequency specifically than is needed to get the pictures. So speaking to what you just mentioned, especially in under 10 weeks, 8 weeks, specifically, all of that, we do not turn on the power Doppler, the color Doppler, to get pictures with color because that is a higher frequency. And up to 8 weeks, you have what's called, at 8 weeks, you have organogenesis complete, which means the beginning of all the organs is complete by 8 weeks.
Wow, so fast, huh?
Yeah, it's so fast. And that's about the time we're scanning babies, and all of a sudden there's a fully formed baby in there. Everything's there. It just needs to grow. So no ultrasound tech worth their salt should be doing any sort of color Doppler finding the heartbeat because that frequency is too high. We don't want to get in the middle of any sort of organs forming or anything like that.
Maybe that's what they were told and we're a little confused.
I'm guessing.
Yeah,
I'm guessing that's where they were going because we are all trained that way.
Yeah. Okay.
But yes, the only reason I would do color Doppler that early is if I don't see a heartbeat. If there's a baby in there and it's not moving, I don't see the heartbeat, I need to confirm that there is no blood flowing or anything, then I would put it on. But that's only when I'm absolutely sure.
I could imagine my brother and his wife being in there and asking, does this baby have a heart defect? And them saying something to the extent of, we don't look this early kind of thing. Yeah, that makes a lot more sense.
I would say that might be why. The other thing is I tell people my standard story when they ask me this thing because it's a concern. It absolutely is a concern. So there was a scan done. I need to look up where this was. There was a study done at one point where they took a mother rat and put her in a vise, pregnant, right? Put her in a vise and put in an ultrasound probe against her stomach and left it there for a long time, didn't move it in one spot. Those baby rats came out with brain damage. Doesn't surprise me at all. One of the things is if you have a tech that, I'll blow my own horn here a little bit, that knows what they're doing.
Hand wave.
Hello. I'm not God, but I do know what I'm doing and I know where to go if I find something that I don't know what it is, I know where to figure that out. That I'm moving that transducer all the time, and I put it down long enough to get the picture. I take it off. I put my annotation on the picture, whatever I'm going to do, save it, and then we go back and get another one. So I tell people, we may schedule 45 minutes or an hour for the ultrasound. That transducer is not on your stomach any longer than maybe 10 to 13, 15 minutes, maybe, and probably less than that.
It reminds me of our prenatals a little bit, that most of the time we're just chatting. The very end, we're kind of doing vitals and things like that. But I could imagine, just from being your patient and being in ultrasound with you, that a lot of it is like explaining what you're seeing and not necessarily having the probe on the whole time. Yeah.
No, I will not leave it on there longer than I need to get the picture. Just to be careful.
Yeah. Can you explain to people who maybe don't even really understand what ultrasound is? Maybe we should have even started there.
Oh, sure.
But
sure. I got a great story on that one.
Yeah. How is it that you're even able to get these pictures for people curious?
I was at somebody's house last weekend, and their two little girls were sitting on the back of the sofa, and they were watching this whole thing. And I looked at them and I said, "So you've seen a bat fly, right?" And they're like, "Yeah, we've seen a bat fly around." And I says, "Well, you know how a bat gets around. They're doing little clicks. They're sending out little clicks. They don't see that well, but they're sending out little clicks, and those clicks are bouncing off of things. And they're able to tell by how long it takes that click to come back and from what angle and all of that. They can tell where there's things in front of them, and they can tell how far away it is." Same sort of idea with dolphins and the sonar that they use, that they're sending that out, and they can tell where things are. The ultrasound does exactly the same thing. It's got a little crystal inside of the transducer, and that crystal vibrates. When you apply electricity to it, when you turn the machine on, it vibrates and it sends out a sound wave. And I'll hold that in the air and have them look at the ultrasound machine, and there's a black picture there.
Is it an actual crystal?
It is an actual crystal. Yeah, there's a series of crystals.
You're more woo-woo than I thought.
Yeah, they're very special crystals, and it's cool because you have like different probes. You have like a whole line of them, or you have, in the case of a heart one, an adult heart, which is like a little tiny square. There'll be a little tiny bunch of them in there. Anyway, so when I'm holding it up in the air, we're not getting a picture because those sound waves are going out in the air. But when I put the special gel, and really it's not that special, we can use olive oil, we can use hand sanitizer, we can use all kinds of things. But anyway, the gel that I use, which is basically thickened Jello water for all practical purposes, and you put the probe against that, and what it does is it takes all the air between the surface of the transducer and the mother's stomach. And so now the air is gone. And so those sound waves are going through that gel straight into and bouncing off of the structures that are inside wherever you're looking at. In this case, we're looking at the baby. So it's bouncing off everything in there and showing us a picture of the baby. So they're like, "Wow, that is so cool." And I will tell you, going back to the risk thing real quick, I wanted to get in there. So, my husband is full-blooded Korean, and his brother married a Korean girl from Busan. My husband was the only one that didn't marry a Caucasian. But anyway, so my sister-in-law with her two kids, this was the first time I'd ever been exposed to that. She had, in that country, they do that, ultrasounds every single month. And I have had other women. Recently, I had one from Ukraine, I think, somewhere. And we did the first ultrasound, and then everything was fine. And then like a month later, she called me and she says, well, when are we doing the next ultrasound? And I'm like, did I miss something? Was there some reason? And she says, well, in my country, we do them every month. And I'm like, well, okay, if that's what you want to do, great, we can do that. But yeah, in other countries, they're done a lot more frequently than we do, even in this country. So, in the hands of an ultrasound tech that really knows what they're doing, you're safe. You're safe. And the information that you're going to get is going to be really useful in the long run. Knowing where that placenta is, knowing where the cord is, if there is something going on with the baby that needs to be taken care of after birth, or whatever needs to happen. If it was me, I would want to know that before delivery so that we could make preparations.
Yeah.
We just, in the end, any midwife, any ultrasound tech, we want to keep this as safe as it possibly can be for both the mom and baby. And we want a great outcome, however that's going to be. And so ultrasound is more information.
Two things I find myself saying to families that I'd love to make sure are accurate. We hear stories from the midwives that are teaching us, and then we just keep telling them. So I like to check in every once in a while. Is it true that ultrasound and Doppler are the same technology, but that Doppler, the handheld that listens to the heartbeat of the baby, is actually more like higher frequency and more powerful than ultrasound? The thing I heard was that 5 minutes of Doppler is equal to a half-hour ultrasound. Do you know anything about that?
Wow, I would never use Doppler for 5 minutes. Definitely not. So yeah, they are they are the same technology. Ultrasound, you are still sending out sound waves. And in the case of Doppler, what that does is it's sending out sound waves and it's bouncing off the blood vessels in the arteries. It's bouncing off the blood vessels. There's a whole thing that they teach us in physics, ultrasound physics, about the Doppler effect. And where you can think about that is suppose you've got a fire truck that's coming, and they've got their alarm going, and the alarm is getting louder and louder and louder as it comes to you and passes you. It's at the loudest, and then as it goes past you, it gets softer and softer and softer and softer. That's kind of the theory, the physics behind Doppler. So the difference between them, I guess you could say, is that ultrasound, just straight ultrasound, is bouncing off everything in the uterus or whatever you're looking at. In the case of Doppler, when you go into that one, Doppler, you are specifically bouncing off of blood vessels. Doppler, you're not going to be able to get a waveform looking at the gallbladder, say. You don't have any blood vessels moving in there. And then what most people concern themselves with is the frequency and not using. So there's different levels of Doppler. There's your straight Doppler, there's power Doppler, there's color flow Doppler. And straight Doppler is what we use with babies just to get the heartbeat. Okay. And that's all I would use at less than 8 weeks. When we're at 20 weeks, we might use the color Doppler to get the blood flow. You're safe using it at that point. And then there's power Doppler, which is the highest frequency. Color Doppler is a little higher than just straight Doppler. Power Doppler is like the highest, or about equal to color Doppler. And that one, we can actually see the blood flowing in the arteries. In an adult, we can actually see the blood flowing in the arteries. In a vein, we can see it going back and forth while you're breathing, all that kind of thing. But that's not something that I would really ever use with a baby.
The one I'm referring to is like the ones midwives use prenatally and in labor. Is that the straight Doppler that you're talking about, where we're not getting a picture or anything, we're just getting the heartbeat?
Yeah, that's the straight Doppler, what you're doing, where you just put is it like the earphone that you put on the stomach and you listen to it?
Yeah. And I've also been told too that it's very loud for babies. We always kind of tell our families that I've heard it compared to like a freight train coming into station, that some babies can get like startled by it or, elevate their heart rate temporarily. Is that a true thing that I'm saying to people?
Well, I wasn't sure about that for a long time. I heard it too, and I actually looked it up.
Okay.
And there is research that says that, yes. Now, where I come down on the side of that is, and where I have seen babies kind of, maybe move away from it a little bit or something, or I might extrapolate that that's what's going on. If you think about sound waves in water is very conductive to sound waves. And if you think about how like a deaf person is able to hear music, they hear music through the frequency coming through the floor. They can feel it. Babies are very attuned to their environment. They know anything that's going on in their environment. So they can feel, I'm absolutely certain they can feel the sound waves rippling through the water. Can they hear them like a freight train? I don't know. But there again, we keep the ultrasound as less as the two. One thing I have seen, and I have no scientific studies to back this up, it's just been circumstantial. When I get called in at 41 weeks and we do the ultrasound, I'm wondering if that ultrasound the sound waves doesn't have something to do with causing some contractions, because I have seen it too many times to be more than circumstantial that women will go into labor within 24. And that's why I usually don't go back and do a biophysical more than once, because they deliver within pretty short period of time. One of the new things that we're doing and is when you're that late in pregnancy, along probably 36 weeks or later, we're doing, going back to the Doppler thing, we are looking at the umbilical artery Dopplers and taking measurements of those, because if you watch, there's a certain waveform. If the baby is getting into distress, if there's problems, you're going to see it first in the umbilical artery Doppler. And there's a certain waveform that you will see. So we're doing a lot more studies with that now, and it's standard now. Every ultrasound that I do, 32, 33 weeks, 36 weeks on, I automatically do those. And if there's any question earlier than that, I will do them. I will do them.
Yeah. One thing our families have loved with working with you too is your flexibility, because sometimes families are feeling a little nervous about the risks, or they want to, only do what's necessary, and they're trying to minimize interventions. And with you, like, I remember having somebody who was like, I just want to rule out twins. I don't need,
I remember that.
I'm just like, I've got it in my mind, and everyone says I'm huge and all these things. And she's like, I don't need a full anatomy scan. I just want to be like, no, you have one baby, and that was exactly what you offered her. Whereas, somebody else is like, yes, I want the full kit and caboodle. I want the whole anatomy scan. But that if somebody is nervous about something, you can tailor it and customize it and give them just what they're looking for. Yeah, that's been really helpful.
Sure. Yeah. My machine also does 3D, 4D technology. It was one of the first ones that was done with this. So I offer that too. As it's no extra charge. It is offered as the anatomy scan or later on whenever they want it. But there's a lot of parents that just don't want to do that. And so we don't have to do that. And, and I get a lot of, like what you're saying is parents saying, oh, we just want the minimum. We just want this. So I do.
Yeah.
I tailor it to what they're comfortable with.
Yeah.
Comfortable with.
I'm looking at our time, but one last question I had. Is there any,
that was fast.
I know, right? Is there any like really common myths about ultrasounds or things that you like hear all the time where you're like, I need to clear the air about this real quick?
Oh, it is. I get that a lot, going back to the risk thing, that this is going to damage the baby, we're going to have defects, all that kind of stuff. Yeah, no. And going back to, my sister-in-law who has them every month. And who had them every month. And they do that in other countries. If there was any kind of damage to the babies doing ultrasounds, a lot, we would have seen it by now. In this country, we don't even do them that often. And so, that's mainly the thing I hear is the frequency, a whole idea, is frequency too high and all that kind of thing. And no, we keep it as low as we just need to keep the picture.
What about the handheld Dopplers that women are buying and just like keeping at home to just listen to their baby? Are those like have safety studies on them? Like, do women need instructions on like how like safe that is to just like do whenever they please at home?
I would be a little concerned, just because I don't know that they've been out long enough to have studies done on them.
Yeah.
You try to keep the frequency. Those handheld ones have frequencies, and you do try to keep it as low as possible. Now, I will say, when I was pregnant and I had access to the machines at the hospital, yeah, I was in there the second I thought I might be pregnant. And that was like amazing when I was in there and I was scanning myself and I could see that little heart rate, dunk, dunk, dunk in the middle. And then I could see my femoral arteries, dunk, 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 dunk on either side. And I was like, there's somebody in there and it's not me. So and the first time the baby got hiccups, and your whole entire stomach is jumping around, and I was like, and I went racing in there and I was scanning myself. He's got hiccups. Okay, it's okay. Yeah, so I get it when moms have that,
especially if somebody's had a loss or things like that.
Exactly, Sophia. I get that, and it can really help you decompress, de-stress. If maybe you're not feeling the kicks yet, and maybe you need to hear the heart rate, and that will help you de-stress. Stress is not a great thing for anybody, and especially a mom.
Yeah. We always talk about risks and benefits and like making sure they outweigh the other. And sometimes we're like, and if you just need to see your baby, like that's fine too. It doesn't have to be a medical reason, like you could also just want to see your baby.
Yeah, I mean, Paula, one time years ago, she called me in because she had a mommy that just needed to go into labor.
Yeah.
And she called me and she said, can you just come show her the baby?
Mm-hmm.
That's all she needs to see. And I went and we spent some time just looking at her baby.
Yeah.
Golly, she went into labor that.
Sweet.
There's a whole mind-body
Yeah.
relationship going on here.
Well, for people who would love to connect with you, obviously our clients, we connect them directly to you, which is also another great thing because sometimes when we refer out and we go through insurance and all that, which we're totally happy to do, they're like, yeah, we have an appointment in a month. And it took like 2 weeks to even get somebody on the phone to tell us that. But
Yes.
usually when we're messaging and connecting people with you, you're very available and it's so easeful. But how can people reach out to you? Can they just reach out to you? Do they need a provider referral? How does that all work?
Well, no, I should say they do need a provider referral. Well, they need to have a provider that I send the report to. I have done things where, we were sending to doctors in Mexico or, wherever, as long as I have a midwife or a doctor to send it to legally. Otherwise, it's like I'm taking responsibility for care or the radiologist is taking responsibility for care. So somewhere along the line, we need a medical person to send the report to. But yeah, you can just call me. My number is 707-337-8308. Please text me. Don't leave a voice message because my phone doesn't always notify me that voice messages are there. And I don't want to miss you. My email is Karen Miller Hahn, KarenMillerHan as in Nancy, at yahoo.com. Again, send me a text message on the phone if you can.
That's the best way.
That is the best way to send it. I don't always check my emails as often as I should, but I am checking my texts all the time. And yeah, if you're with a midwife, every midwife in about 100-mile radius connects with me. I do a lot Kaiser. I do a lot of the hospitals around here. If people would just rather come to me and do an out-of-pocket, we can do an out-of-pocket thing, or I can also give you invoices to send to your insurance, and then your insurance will either apply it to your deductible or reimburse you one way or the other.
Great.
Yeah.
Thank you so much for coming on.
Thank you, Sophia. This was so great. Thank you for this opportunity.
Thank you for listening to our podcast. If you enjoyed what you heard, please rate, review, and subscribe. If you'd like to follow along, you can find us on Instagram at Born Wild Podcast and Facebook. You can go to our website at www.bornwildmidwifery.com. See you later.